common things that patients come in for is hip arthritis. And usually what that feels like is it's pain within your groin, usually deep within the groin, and it hurts with any range of motion of the hip, any rotation of the hip. And patients tend to experience a lot of discomfort when walking, running, and even when sitting for long periods of time. So it's not uncommon for me to get complaints about long drives causing a lot of issues deep within the groin that are all stemming from the arthritis. So oftentimes I get the question about what exactly is arthritis, and what arthritis refers to is when you lose cartilage around the bones in your joints. So in this instance, in the hip, the cartilage that makes up the acetabulum or the cup and the ball of the femur starts to narrow, and we can see that on X-ray as joint space narrowing. And on X-ray, what we see is just two bones, and we can't see the cartilage. But as the cartilage gets thinner and thinner, what you see is that the femoral head and the acetabulum or the cup start to get closer and closer together. So until eventually it looks like the bones are sitting on top of each other. So a lot of times you'll hear people talk about bone-on-bone arthritis, and that refers to the complete loss of cartilage. So when patients come in and I diagnose them with hip arthritis, there's several forms of non-operative management that we can go through before having to consider the ultimate solution or the ultimate treatment, which would be a hip replacement. At this point in time, there's no way to reverse hip arthritis, but we do have several treatment methods at our disposal that can help to minimize the symptoms. So first and foremost is weight loss. So any patient that's overweight, I always recommend to meet with a dietitian or to form some type of diet and get on as much of a workout program as possible to try to lose weight. The pain and the force that a joint experiences is directly proportional to the amount of weight. So I think the single best thing that any patient can do to minimize the pain associated with arthritis is to lose weight. In terms of along the same lines of that would be physical therapy. So strengthening all the muscles around the hip. So that includes your quads, your glutes, your hamstrings, core musculature, and working on flexibility around the hip. All those things can help offload some of the pressure that the joint sees and helps to alleviate some of the symptoms. So every patient that comes in, I recommend trying to do some form of weight loss and getting into physical therapy to work on strengthening around the hip. In terms of medications, I think the single best medication is anti-inflammatories or NSAIDs. So these are the group of medications that are like Advil or ibuprofen, Aleve or naproxen, or Mobic or meloxicam. And so all of these directly influence the inflammation around the hip and can help alleviate symptoms. Tylenol is also a good drug that you can use in combination with one of the NSAIDs, as it's a pain reliever, and it works directly on the brain actually, and so it can be taken at the same time as the anti-inflammatories because it has a different mechanism of action. The next treatment options consist of injections, and there's two main types of injections that I use for hip arthritis. The first is steroid, and I typically use the type of steroid called triamcinolone and or dexamethasone. But different people use different types of steroid. But this can, I use ultrasound to locate the hip, and this with a small needle can be placed into the hip joint, and a small amount of steroid can be placed into the hip joint, which usually will give several weeks or possibly months of relief for a patient. A lot of the time, this works well in combination with the physical therapy because you can get a lot of pain relief, and which gives you the ability to better participate in physical therapy and exercise and possibly lose weight. So while the steroid itself is not reversing the arthritis, it can directly control the symptoms such that you can participate better in physical therapy. And it also works well for patients that are maybe going on a trip or have some event coming up. It can very reliably provide some short-term relief. The last type of injection that I use is called PRP, which stands for platelet-rich plasma. It's a newer form of injection, but it also essentially works as an anti-inflammatory in the hip. And the way PRP works is we draw about 60 milliliters of your blood, and we use a centrifuge to spin it down and centrifuge off most of the red blood cells, a lot of the white blood cells, and what you're left with is the plasma portion of blood. The plasma portion of blood has several factors in it that, when introduced into the hip, again with a needle under ultrasound guidance, can lead to pain control in the hip. This is a newer form of treatment that insurance does not cover yet. So at our clinic, this costs $325 in cash. A question I get a lot from patients is when they should have a hip replacement or when they're ready for a hip replacement. And I think it's important to know that I think this is a very individual decision for every patient. So even though your x-ray may show very extreme arthritis in one case, or maybe just moderate arthritis in another case, we don't operate just simply based on the x-ray. So when the pain gets to the point that it's affecting your ability to sleep or ability to do the activities you enjoy in life, or even affecting your ability to do small activities like tying your shoes or just bending over to pick things up, I think that's when I usually recommend starting to consider your surgical options, which would be a total hip replacement. So when you decide to opt for a total hip replacement, there's two main approaches that different physicians will use. You can either go anterior, which means you're coming in the front of the hip, or you do posterior, which is coming from the back of the hip. In my practice, I do a posterior approach to the hip. When you perform the surgery, what we're doing, if you look at this model, is you're cutting off the femoral neck with the ball attached to it and the arthritis there, and then you're using a reamer device to go into the acetabulum to shave out all the bad cartilage and make room for a cup. So during the procedure, a cup similar to this is placed into the native acetabulum or into the native cup, and the cup has a very gritty surface that latches onto the bone, and then the bone grows into the cup to make it a very solid fit. There's also the option to place screws in there for added fixation, and that's a decision that I make in surgery whether or not to add screws. After the cup is placed, there's then a plastic piece that fits inside this cup. So you can see on this model, there's a nice plastic piece within there. The plastic piece is kind of the biggest development recently in hip replacement, in that in the last 10 to 15 years, the engineers have developed a plastic that wears at a very, very low rate, which increases the longevity of the hip replacement. So in the past, you would hear about some hips wearing out or requiring a revision at very early, 5, 6, 7, less than 10 years. And the big advancement in hip replacement over the last 15 years was the development of this very sophisticated plastic that wears at an incredibly low rate and then allows the hip to last longer. The second part of the hip replacement surgery is on the femur side. So the native neck and ball of the hip is removed, and what we replace it with is metallic pieces. So On the femur side, it looks like this. And what we do is we match the size of this stem to the native femoral canal. And again, most of the time on this, I'm not using any cement, and this is purely a press fit, meaning that it's just the tight fit in the femoral canal, which allows this to hold, as well as the gritty surface around the stem. And again, the body will grow into this and make the bond even stronger as time goes. This piece can be different materials based on the company, the implant that's used, and based on some different varieties, but usually it's some type of cobalt chrome or oxenium metal, or sometimes can even be a ceramic piece. After a hip replacement, the patient will be admitted to the hospital for one night. I do my hip replacements early in the morning, such that you can work with physical therapy twice on that first day. They'll get you up walking on the very first day right after surgery. You'll be feeding yourself, going to the bathroom on your own, no catheter or anything like that. The plan will be to be discharged the following day from the hospital, and you'll go home where a home health nurse and physical therapist will be arranged to come visit you at the house. I like for my patients to remain in the house and see home health and physical therapy for 3 weeks. I think the first 3 weeks is very important just to heal and take it easy. Most patients will be on using a walker or a cane for the first 3 weeks in order to ambulate and allowing all the soft tissues to heal. I close my incision with a stitch that goes inside the skin, so there's no stitches that need to be plucked out at the end of the surgery. I have you wear the bandage for 3 weeks. You can shower and clean yourself as long as that bandage stays on and that the incision remains clean. I will follow up with you at 3 weeks post-op to make sure that incision is healed well. And it's usually at that point that patients start to wean off either the walker device or the cane. And it's my goal for everybody to be walking without a limp by 6 weeks post-op. In terms of driving, if this is your right leg, it's probably, it'll take a little bit longer to get to the point where you could drive. If it's your left leg, I'm fine with people driving after the 3 week mark. For the right leg, it'll be based on your comfort. But again, you'd have to wait at least 3 weeks, but usually for the right leg, it can be somewhere along the lines of 4 or 5 weeks before people are driving. In terms of work, I'm fine with patients going back to light duty after 6 weeks. I would like for patients to remain out of work for 6 weeks to allow for healing. If it's a more demanding job or something that requires a lot of walking or lifting or any type of manual labor, I usually recommend staying out of work for 3 months in that instance. I do consider the patient pretty much fully healed at 3 months and would have no restrictions at that point. In my experience, patients tend to continue improving for up to a year and sometimes 2 years out from the procedure. In terms of going home from the hospital and medicines you have to take, the only medicine that you have to take will be for DVT prophylaxis. DVT is a blood clot and forms just from being a little more sedentary than normal. This is a low risk, probably less than 1%, but I like to minimize this risk as much as possible by adding in some type of blood thinner agent. If you do not take any blood thinners, you will be placed on aspirin 325 milligram daily for 30 days. If you currently take a blood thinner, then you will just resume whatever blood thinner that is that you were taking beforehand.